Okay, so ABG, like when to get one. So we talked about reasons why the numbers might be off, kind of hinted at some of the causes and some of the fixes, but when do you actually get an ABG? When should you get one? So obviously respiratory distress, that's going to tell you about the O2 status, it's going to tell you about if they're compensating, if they're blowing enough CO2, right? If someone's really, really sick, they might be tiring out, right? Like respiratory wise, they might be tiring out. Tidal volumes will go up or down if you're tiring out. Go down, right? And the CO2 can start going up, right? So you see like a PO2 of 50, is that good? PO2 of 50, and you see a PaCO2 of 50, is that good? No, that means there's CO2's building up. That's called the 50-50 club, and that's someone that probably needs to be intubated, right? If they're still awake, we have some other strategies we can try, we'll talk about today, but for the most part, they probably need to be intubated. Okay, so also, you know, where they had an ABG and the PO2 was 50 on 2 liters, and do another ABG in 2 hours, and the PO2 is 50 on BiPAP, which is one of our last steps before intubation. That's probably not a patient that's going to be tolerating another 4 hours of just trying BiPAP still, right? So if they have a PO2 that's like 120, right, and they're in respiratory distress, it might be anxiety, right, or it could be pain or agitation. So that's an ABG can help us differentiate whether it's like a truly a hypoxia situation or it's like an anxiety situation as well, right? Hypotension. Why would an ABG tell us what would ABG tell us about hypotension to tell us that we're maybe a little more concerned? Yeah, if someone's hypotensive, because oftentimes we order an ABG on someone who's hypotensive, and RT goes in the room, is like, I'm room air. What am I doing here, right? Then you have to convince them. No, we want to assess. We want to assess if they have lactic acidosis, right? So no hypotension is low blood flow to the tissues, right? And the tissues are going to start producing lactate, right? And the pH, the reason why their blood pressure is low could be to the buildup of lactate, right? Because what happens when your pH is low? Do your proteins work? Does actin and myosin work, right? Where's actin and myosin? It's on all muscles. It's on cardiac muscle. It's on skeletal muscle, so they're weak and fatigued. It's also on smooth muscle, right? Smooth muscle of the vasculature. So the vasculature relaxes and then vasodilates. And do you want to vasodilate someone who's hypotensive? No, you want them to be, clamped down. You want their SNS to be firing, and the SNS can only fire as much as it needs to, right? It's going to go down. It's going to try to innervate, but if it's going to hit those vasculature, and it's going to say squeeze, and they're like, I can't do it, right? Because their proteins are all denatured. Okay, if someone's altered, why would you get an ABG? Because hypoxia causes altered mental status, elevated CO2 causes altered mental status, and acidosis makes your proteins not work, including your brain. So it makes you altered. Okay, and then how do you know someone has metabolic? What else would tell you that they have metabolic acidosis, and the metabolic acidosis is getting worse, right? That's where we talked about looking at the chemistry, right? Tells you if you see the bicarb starts going, it's being utilized, right? So here the bicarb is normal, right? And now we're utilizing all the bicarb, right? The bicarb is getting used up because binding to the acids that are being produced, right? We can do other labs to assess if they have ketones, if they have lactate and such, but we can see on the gas on the chemistry that bicarb is going down, right? And we can also see that what's called the anion gap is going up, right? And there's such thing as a high anion gap metabolic acidosis and not a low, but a normal anion gap metabolic acidosis, because normal anion gap is 12-ish, right? So normal is about 12, right? Sorry, going right here. So you can have an anion gap that is going up and up and up, and it could be because of a lack of or a utilization of bicarb, right? So what is anion gap? You maybe see in textbooks where they put the parentheses and they've not distributed the factors like what you would do in math, right? If you have a negative, you can distribute across all the positives and make them all negative. So it makes more sense if you actually do the math and just, sodium minus bicarb minus chloride. That is your anion gap. And the whole purpose of the anion gap is to measure what's not measurable, right? Because it's a gap, right? You can't do a lab for hydrogen ions. You can't say, oh, your hydrogen ions are 12, right? All we can do is say, hey, acids are positive, right? So if I'm at a whole bunch of positives here, and normal is sodium minus bicarb minus chloride is 12, and I got 12 acids, well, that's an anion gap at 24. Sometimes you see anion gaps at 36. That's a lot more acids like ketones and DKA. We know someone's out of DK, the DK is resolved when the anion gap is normal because there's no more acids being added to the equation. Okay, so sodium, what, 140, right? Minus bicarb, 24, minus a chloride, let's make it even at 104, equals 12, right? You shouldn't have acids at baseline, right? If you do have acids, we're adding them to the equation. So that's going to make my anion gap go up. Okay? So that's a high anion gap metabolic acidosis. There is such thing as a NAGMA, a normal anion gap metabolic acidosis. We talk about that more in renal, right? That's where you lose bicarb. Not where you're utilizing bicarb and you're gaining acids, but you're not gaining acids when you have diarrhea, right? All you're doing is losing bicarb and your pH is going down. So if you're losing, your pH is going down, your bicarb is going down, I still lost bicarb, right? But I've gained chloride in the meantime, right? Because your body's going to equilibrate. It's going to say, hey, you lost a negative ion, let me throw a chloride in there to try to fix that. Okay, to fix that balance. All right, so then venous CO2 starts turning down, right, less than 22. That's a trend that tells you that someone's at risk for metabolic acidosis. And getting an ABG would give us a firm pH to tell us, are they 712 or 732? Because which one's more concerning? 712. All right, so metabolic causes. So you kind of alluded to this about bicarb being lost or loss of hydrochloric acid. You want to close that guy? All right, so yeah, so what you have here is a pyloric sphincter, right? And that's our key line in the sand. That's what tells us if we have like what the cause is, right? If they have diarrhea, you're producing bicarb right over here in the pancreas, right? Your pancreas is producing your bicarb. It's squirting it into the duodenum, not into the stomach. The stomach is right there, proximal to the pyloric sphincter. But anything below the pyloric sphincter that's causing issues, look like diarrhea, right, including bicarb and all the pancreatic juices, all these things would go all the way through and cause a loss of bicarb, right? If I lose bicarb in my scale balances, what's I can do to my pH? It's going to drop it, right? I didn't gain acids. All I did was lose bicarb, which maintains normal pH, right? So if I lose the bicarb, I'm going to have a drop in my pH, okay? And then on the flip side, if I have, hydrochloric acid being produced by my stomach up here, right? Hydrochloric acid being produced by my stomach, HCl, and that if I have all this acid being produced and then I'm going to vomit it, that's going to cause a what? Alkalosis. So when you have a vomiting, alkalosis, right? So you're going to have alkalosis when you have vomiting, right? And when I'm pooping too much, I'm pooping on my acidosis, I'm going to have metabolic acidosis when I have too much poop kind of my acidosis, right? That's going to be how you know which one's which, okay? So you have metabolic alkalosis or you have metabolic acidosis that results from GI, right? So yeah, so when you drop an acid, we talked not like, for fun, but when you drop an acid, a solution, like an acid like lemon acid or citric acid, right, vitamin C, you put it into a water, it's going to make it fizz, right, because it's going to be, there's some CO2 there, but also if it creates hydrogen ions, that's technically an acid, right? All right, so anyway, so we have what did I say here? So metabolic alkalosis happens when we're gaining bicarb, right? So metabolic alkalosis can be you're gaining too many Tums, right? So when took too many antacids, and it's going to be neutralizing the hydrochloric acid in our stomach, and those medications, they neutralize it into a gel, so you can't reabsorb the hydrochloric acid again in the GI tract. So that's going to cause a metabolic alkalosis. That's not as common in the hospital setting or ICU compared to giving too many potassium wasting diuretics. And what's a potassium wasting diuretic? As an example of that. So Lasix, right? So everybody gets Lasix, everybody gets furosemide. So too much furosemide, right? Furosemide is great, it does wonders, but sometimes it's on the profile for 5-7 days. And we can see that they're starting to get alkalotic. So we would see what on the chemistry would start going up. The bicarb, otherwise known as the CO2 on the chemistry, right? So if you get an ABG, you will see that the ABG will reveal a bicarb going up, but you will also see on the chemistry, which probably gets done every day anyways, you'll see the bicarb go from 24 to 28 to 32, and then all of a sudden they're like, hey, there's keep failing breathing trials on the ventilator, I can't figure it out. Well, their bicarb's 32. How is the body going to react if your bicarb's 32 and your pH is super high, 750? What's your body going to do to fix that? It can in one day get rid of more bicarb, right? But that's not going to happen because you keep giving them Lasix and they keep getting rid of potassium. The bicarb keeps going up, so that's not going to work. So how else do we fix? What's the body going to do to compensate? It's going to hold on to CO2 to neutralize the alkalosis, right? And how does it hold on to CO2? It's going to reduce the tidal volume and reduce the respiratory rate. And then you're on a breathing trial. Come on, breathe. And the brain's like, nope, not today. You're not pH balanced, right? So that's an important thing to look at for the trends to see if we're getting too alkalotic, right? A bicarb drip that is unchecked, right? That's another reason that we want to make sure that they're not getting too much bicarb. Is it our fault, right? And like we said, GI causes, right? Why are they alkalotic? Because they alkalosised all their hydrochloric acid from their stomach, right? Also, you have other fancy ways to get stuff out of the stomach, such as what? NG tube, right? You can put an NG tube in there, right? And that'll pull out a whole bunch of hydrochloric acid too. So vomiting, NG tube dissection, right? It's iatrogenic, means that we did it, okay? And then now switching gears, metabolic acidosis, right? You lost the bicarb. Well, where'd it go? I don't know. That's my daughter tells me all the time. Where's your book? I don't know. All right, so they lost it, right? And how they lose it, right? They either bound to an acid or you lost the bicarb literally through the acidosis route, right? So it's going to be diarrhea. That'd be the most common reason. Or fancier ways. What's our fancier way to have diarrhea? Or fancier way to lose bicarb, I should say.
Like bowel regimens?
That could be. Usually bowel regimens are for someone who has constipation. And constipation doesn't make an ABG change unless you start getting like ischemia. But if they have a They have a stoma of some sort. They got a little stoma right here. They got an ileostomy over here, or they got a colostomy over here, right? And too much output, right? That's otherwise known as diarrhea. Diarrhea is defined as more than 200 cc's per day, right? Or more than 3 bowel movements per day. That's diarrhea, right? So greater than 3 per day, greater than 3 per day, or a greater than 200 mLs. I might have put it right here. So, all right. So yeah. So diarrhea, ostomies. These are GI reasons why you would be losing bicarb, right? It's not because you're gaining acids, right? And metabolic acidosis, which is definitely up there like 8 times out of 10. Usually why you're acidotic is because you are gaining acids, right? But yeah, there are other GI causes for it. All right, so systemic causes, the buildup of acid like we mentioned, you got ketones, you got ingestions, lactate, and uremia that we mentioned before, right? You got ketoacidosis due to low insulin, and therefore you break down lipids instead, and that will then produce ketones, acetoacetic acid, beta-hydroxybutyric acid, and acetone. Acetone's not an acid, but these other guys are what? Acids, right? We're building up all these acids that gets dropped into a solution, creates hydrogen ions. Bicarb will come in to save the day and neutralize it. And what will happen to your bicarb once it starts neutralizing keto acids? It's going to go down, right? And then we got ingestion. So antifreeze, glue sniffing, meds like an aspirin and such, all these things will start dropping our hydrogen ions, as well, our bicarb as well, right? They're going to neutralize those hydrogen ions, and bicarb's going to drop, and therefore bicarb caused the drop in pH. So the bicarb caused the problem. That's then known as a metabolic problem, not a respiratory problem. And then we have a lactate buildup due to low blood pressure or due to low O2, right? One of the two, right? It could be due to anemia. It could be due to low PO2 due to a respiratory problem. Okay, but usually that's more commonly sepsis is the most common problem, and hypotension, most common reason why we have a buildup of lactate. And we have a whole lecture on shock, right, where you figure out if it's cardiogenic, hypovolemic, if it's neurogenic, if it's anaphylactic. Those ones aren't as common as septic shock being our reason. Okay, and then uremia and renal failure, where you can't get rid of the acids, so they build up. Bicarb's going to neutralize them. Bicarb's going to go down, and the potassium builds up, and your body's going to say, hey, that's way too much potassium. Let me put the potassium back in the cells in exchange for hydrogen ions, and therefore the hydrogen ions go up and up and up and up. Okay, and then it goes up and up and up. It's like, whoa, let's put the hydrogen ions back in the cells, potassium right back out. So high hydrogens equals to high potassium, and high potassium equals to high hydrogen ions. They all go back and forth. Okay, and we talk about GI causes, right? We're losing the bicarb in the stool. Okay, so control, we've kind of been alluding to these things, right? So respiration is fast, right? Blood is fastest, right? So you have to be able to breathe to get rid of CO2, right? That's one of our ways to compensate, right? We could get rid of CO2, we get rid of that extra acid when we have a metabolic problem or a respiratory problem, probably. When would you be getting rid of CO2 to try to balance the equation? Would that be a respiratory problem or a metabolic problem? No, metabolic problem. If you have metabolic acidosis, you're going to get rid of carbonic acid to fix the acidosis, right? That's how it's compensating. But yeah, on the flip side, you can have a respiratory acidosis because you're not breathing. So then your body's going to say, well, I'm going to try to make them breathe faster, but maybe you have like a medullary injury, you have a neuro patient, and they can't breathe faster. Or, you know, some little nurse on Med-Surg 2 or Tele or even in the ICU gave some too much Dilaudid, right? Or in the PACU, and then they call a rapid response up there, and they're saying, you know, what are we going to do now? I mean, the brain's trying to make them breathe faster, but they can't, right? So how's it going to compensate? If it gets to the point of too much acidosis, they can try to quickly, blood-wise, try to move some things around, but it's up to us to try to maybe fix it for them, right? So we got CO2 chemoreceptors and O2 chemoreceptors. That's how the respirations will get affected, right? So we start getting acidotic over here. The pH starts getting low, and centrally, in the central chemoreceptors, it's going to say, well, I got to breathe faster, right? CO2 is built up way too fast. I'm going to start to make you breathe faster, right? And then same thing if you have a low blood pressure right here. We'll also do it, but really it's low O2 is what we're talking about right now. Low O2 centrally or low O2 right there, those carotid bodies. If that oxygen level is low, I'm going to start breathing faster, okay? And the kidneys. So the kidneys are very, very slow, as we mentioned, right? So they are going to, they can fix the situation. They can, if you're too alkalotic, they can say, well, I'm going to get rid of more bicarb. If you're too acidotic, I'm going to get rid of more hydrogen ions. It gets rid of the hydrogen ions, it deaminates the glutamate, which is an amino acid, one of our 20 amino acids. And it will take that amino acid, it'll break it apart, get the ammonia out of it, it'll bind it to a hydrogen ion, and you will expel it in the kidneys, right, in the urine. Or straight up, if you have too much bicarb, it will just let it ride, right? Let the sodium bicarb just go on out, okay? And then the kidneys can also do is say, hey, whoa, you are way too alkalotic. What I'm going to do is I can also take some of the bicarb that we might have excreted, right? Sorry, that's the right. So it will balance by making more carbonic acid to kind of fix the situation, okay? And then blood, that's the fastest way to fix the problem, like immediately. So your blood's going to move potassium in the cell or put the potassium out of the cell. It's maintaining electrochemical neutrality. It's always making sure the balance in the serum is balanced, right? So it says, hey, the hydrogen ions are way too high out here. I know that's going to cause problems, and too many hydrogen ions causes low pH, right? So the hydrogen ions are going to go into the cell in exchange for potassium, right? And that's a two-way street. Your cells can compensate either way, right? Because if you are too hypokalemic, right, or sorry, too alkalotic, you're going to then say, well, too alkalotic, I got to fix that. Let's put some potassium out there. Or let's put the potassium in the cell and exchange the hydrogen out there to fix the alkalosis, right? So both ways it will fix the problem. All right, so respiratory-wise, how do we fix it respiratory-wise? So it's the respiratory, as we know, is moving O2 and CO2. That's ventilation, right? And then we get down to the alveoli, and that's your that's actual respiration, right? And then we get down all the way to the tissues, and that's cell respiration, right? Right now we're talking about the ventilation part, the movement of CO2 and O2 out of the lungs, right? And we talked about minute ventilation. How much you're moving per minute is more important than just the tidal volume or just the respiratory rate, because they could be having a tidal volume of 200 but breathing 40 breaths per minute. That's not as great as 600 breaths and breathing 40. One of those is going to build up CO2 than the other, right? So minute ventilation is just your respiratory rate times your tidal volume. It's equivalent to your cardiac output, which is your heart rate times your stroke volume. So minute ventilation will be adjusted, and when minute ventilation is higher, you're going to be blowing out more CO2, which makes sense, right? This is the volume of CO2 I have, and this is how much CO2 I can get out per minute, right? So respiratory rate is changed by the autonomic nervous system. Our SNS will fire when we have any one of these situations here, right? So, and how do they know that happened, right? They have little closed circuit TVs out in the periphery, and they're knowing if the oxygen level is low. They're knowing if the CO2 is building up. And they also know if the pH is getting too low, right? pH is getting too low, the body knows how to fix that by blowing off more CO2, right? Because CO2 is an acid. I don't want that. Let's get it out, right? Because an acid is building up for some reason. Either they have lactic acidosis or ketoacidosis or kidney failure, or they ingest the antifreeze, one of these things, right? So I know how to fix that in the meantime. Let's go ahead and breathe faster, right? So we have little pH chemoreceptors also in the brain that will recognize that the pH is low. And when that happens, right, so low pH will stimulate the SNS to fire off. What does the SNS do? It goes down, there's a lot of things, but it goes down, it's going to increase respirations in this situation. They will also increase your heart rate, so you can see someone who's acidotic, they're going to have a tachycardia until the point where their cells get so denatured because of acidosis that they can no longer maintain ion control and they start getting bradycardic and PEA and such. Right, so there is a spectrum where your body can compensate and it just gives up, right? You get too tired or your cells get denatured, right? So the ANS is what controls respirations. It can slow you down, right? If you're way too acidotic, if you have too much, back it up. So if you have too much alkalosis, right? You're way too alkalotic, you have too much diarrhea or too much vomiting. Why would you be too alkalotic?
Too much vomiting.
Too much vomiting of hydrochloric acid out of your stomach. Your body's like, whoa, we're way too alkalotic. Let's try to fix that. How does it fix it? It's going to make you breathe faster or slower. Which one? Slower, right? So it's going to make you breathe slower. But usually what we're going to see in the ICU or the hospital setting is someone that's going to be getting sicker with ketones or lactate or what have you, other acids, and it's going to start kicking in with a low pH, right? Also, SNS stimulates with low oxygen. You have oxygen levels are low, O2 is low here. It's going to, at the aortic arch and carotid bodies, are going to say, whoa, O2 is way too low. Let's crank that up. Let's bring more oxygen in, right? Does that affect the CO2? Yeah, it does, but really our concern at that point was the oxygen, right? But if someone's really CO2 start building up and building up, the SS is going to try to fire off to make it work, right? To make the respirations faster. But if we got in the way with a ventilator, right, or we got in the way with narcotics, you're going to see the tachycardia, but you're not going to see the tachypnea because you got something physically or chemically in the way. Okay, and BP being low, we have BP receptors here as well. That will also stimulate the SNS, as we'll talk more in cardiac, right? Glucose being low will also throw this off. So these are ways you would see your SNS firing off because of any one of these things: hypoxia, acidosis, hypercapnia, hypotension, hypoglycemia, stress, infection, fever. All of these things would lead to a respiratory what on the ABG? Alkalosis. Yeah, respiratory alkalosis is what happens when you have too much hypoxia, when you have too much hypoglycemia, or even hyperglycemia because it causes dehydration, or too much hypotension. Your SNS is going to fire off. When it fires off, it's going to make you what? Breathe faster, right? It can also compensate for acidosis, but we also have to recognize that the SNS has a big role in making us breathe faster, and that's a cause of our respiratory alkalosis. So you see a pH of 7.52 and a CO2 of 28, right? Well, I know what caused the alkalosis. It was the 28 CO2, right? That's what made me alkalotic. Why? So I can just look one line down and see the PO2 of 45. Oh, that explains it. The reason why they're breathing so fast right now was because of the hypoxia. Or someone gets a blood sugar and they say blood sugar is 45. Well, that's why their SNS is firing off. That's why they're breathing so fast, right? Or it gets, they have hypotension. They got 70 over 40. That's why they're tachycardic and tachypnic right now, right? But there is a spectrum. There's a falling off point where they will keep compensating with the SNS, and then the SNS can't work anymore because of severe hypoxia or severe acidosis or severe temperatures. Okay, so low pH alone can also trigger your SNS. All right, so normal tidal volume is about 500 cc's. Okay, vital capacity I highlighted because sometimes we look at vital capacities, especially with like neuromuscular problems like myasthenia gravis and Guillain-Barré. But usually 500 cc's of tidal volume to 800 is a normal tidal volume, right? And we talk about vents on our next lecture. Normal tidal volumes are 6 to 8 mLs per kilo of ideal body weight. Okay, so you have O2 chemoreceptors and CO2 chemoreceptors that will keep adjusting for situations that might be at hand, right? With hypoxia, acidosis, hypoglycemia, etc. Okay, all these things are inputs. They're inputs that tell the body that something's wrong and we need to fix it, right? And if it starts causing ABG problems, then our body's going to try to respond respiratory-wise, renal-wise, or just with our bloodstream, with switching with the cells. Okay, so adequate tidal volume, right? So again, 500 cc's or so is about a good tidal volume. And your tidal volume, that volume of tide, that volume of air is what has CO2 in it, so you have to expel it, right? So minute ventilation is what tells us, on the ventilator, it's right there. On the BiPAP machine, it's right there. And we want a good minute ventilation about 5 to 8 liters per minute. If you know cardiac output, that's also the same for cardiac output, right? Cardiac output's with each stroke of the heart, with each respiration of the lungs. That's how much volume, and then per minute. So heart rate is how many beats per minute, and this is how much breaths per minute. So they're very similar. Okay, and ideal tidal volumes again are about 6 to 8 per kilo of what's called ideal body weight, based on birth gender, whether it be female or male, right? Because a 5-foot female across the board usually has the same lungs within like 5% or so, right? Whereas a 5-foot male has different little bigger lungs. Okay, so that's the idea: respiratory rate versus tidal volume. Okay, so you can see with the CO2 is going to start changing based on minute ventilation. If I'm breathing, if I have a really, really high minute ventilation, am I going to be blowing off more CO2 or less CO2? Blowing off more. So you can see the PaCO2 is a lot less, right? Compared to if minute ventilation is like 2 to 4, that's going to cause a really, really high CO2. Okay. Ideal body weight, just punch it in the calculator and MD Calc, and it will get it for you. These tables are posted at each station, so you can see if your patient has the ideal tidal volume for their height. Okay. So the SNS response we touched on. So this is going to be to carry you a lot as far as why someone has this disease process and why they're doing what they're doing, why they're breathing fast, why their heart rate's elevated, and it will also help us with ABGs, right? So if we have a hypoxic patient, like we mentioned, a CO2 that's going up, and if CO2 goes up, your pH goes down, but independently, if your pH goes down, your body's going to start responding SNS-wise. Your blood pressure is low, your glucose is low. All these things are going to trip off the SNS. When you have stress or infection, like pain or agitation in the ICU, or you have an infectious process that's brewing, your SNS is going to fire off. When you have a fever, that'll do it. Pain will do it. So all these things are going to trigger the SNS. The SNS is going to fire off from the brain. It's going to go to each one of these little different areas here, and it's going to have an effect, right? It'll go to your sweat glands and make you diaphoretic, right? When someone's hypoglycemic, they're diaphoretic for like plus, right? The sheets are saturated with sweat, right? And when they're breathing really, really fast, their pillowcase is all wet because their SNS is trying to fire off. But if they have that narcotic on board, they're diaphoretic and their heart rate's up and everything's saturated, but they're only breathing like 4 breaths per minute, right? Because we gave them a narcotic to block the SNS, the brain's effect on respirations, right? So what happens with the SNS response on the heart? It's going to increase your heart rate and contractility, make your blood pressure better, right? Because it has, the inputs, has little blood pressure sensors. The blood pressure is low. I know how to fix that. Let's make the SNS fire off to raise that blood flow. Okay, and these guys are going to say I have palpitations, right? And then blood pressure is going to go up. And we'll talk more about receptors in cardiac, right? Beta 2 and alpha 1 receptors are going to be acted upon. So beta 2 receptors are on the dilation side. They're going to dilate, open up more blood flow to the lungs so they can pick up more oxygen, right? Blow off more CO2 if we need to. They're going to go to the heart, increase the heart rate, and increase the blood pressure primarily by the alpha 1 receptors. They're going to bind these alpha 1 receptors here, and they're going to vasoconstrict. All the things that don't need blood supply right now. When you're hypoxic, you don't need your gut to start processing food, right? You don't need your kidneys to start filtering things, right? We don't need our skin to get a lot of blood supply, right? Our skin is our largest organ on our body. So we're going to reroute all the blood from that to our central circulation. They get clammy and diaphoretic, as we mentioned. We're rerouting blood away from the skin, so they get cool, clammy skin, and they start sweating and diaphoretic. When you have an SS response, you're thinking it could be an ABG reason. pH could be low, right? Or CO2 could start to be climbing up, but it could be also these other reasons. So they're hypoxic, hypotensive, febrile, etc. Okay, so here's our respiratory situation. So we are increasing our respiratory and tidal volume when we are hypoxic, right, or hypercapnic. Those are the symptoms that will happen. Okay, and then when they're hypoxic, they be compensating, and you can see on the ABG that they're compensating because they did what? If respiratory tidal volume goes up, what are you going to see on the ABG? You can see a drop in what? CO2. You're going to see a CO2 that's going to be less than what?
35.
Less than 35, right? So yeah, so also when someone has an SS response, they start getting feeling anxious, they start getting tremors, they have feeling of impending doom, right? You can see a patient, you see that on your NCLEX all the time, right? Patients have a feeling of impending doom. Well, it's one of these reasons, that's it, right? Or they have anxiety, right? And it's a mental health question, all right? And then you got pupil dilation, pupils will be dilated, you'll see that, and we have medications that mimic the SNS, like epinephrine. When your SNS fires off, it's literally releasing epinephrine and norepinephrine, right? So someone's getting epinephrine, right? You can look at their pupils and you can see the pupils are dilated, okay? And blood glucose, we'll talk about this more with endocrine and DKA and diabetes, but it's going to start mobilizing sugars. It's going to break down glycogen, break down lipid stores, like adipose, can break down protein stores, okay? And then to sustain this, we release epinephrine immediately, and norepinephrine immediately, but really to sustain this, we go all the way to the adrenal medulla right here, and it's going to make us squeeze out more norepinephrine and more epi. You've seen a lot of patients on norepinephrine and Levophed, and those are given for what reason? What's the reason for Levophed drip? To fix the low blood pressure, right? This only can last for maybe like an hour or 2 hours maybe, right? So to sustain this SNS response, the patient has to do it, then they can give out. So we got to supplement that with norepinephrine. The reason why norepinephrine is better than dopamine and better than vasopressin and phenylephrine is because it's the natural chemical that's getting released during a stress response, right? So yeah, so these are getting released, and then also to sustain it, we also release some other friends here, angiotensin 2 and aldosterone. So if you don't know the RAS system right now, we get to cardiac, you're going to be very familiar with the RAS system. It's used in and out all the time, okay? And ADH, antidiuretic hormones, also get released. That's going to raise my blood pressure. That is your vasopressin, right? Pure vasopressin gets released. Okay, so the kidneys. So we talk about how the kidneys are going to either get rid of excess bicarb or get rid of excess hydrogen ions, or they're going to hold on to that stuff, right? So normally right here in the middle in white, that's if your normal conditions, we're going to get rid of sodium. The bicarb is going to hitch a ride. It's going to get broken apart, and the CO2 is going to get reabsorbed here. And we're going to use, there's our friend carbonic anhydrase. And it's going to reabsorb the bicarb to maintain our bicarb balance in exchange for water, and we can actually stop that hormone or that enzyme, and we can actually make it so that we don't make bicarb, right? And that medication is called acetazolamide. So if someone is super alkalotic, right? Do we want to do the normal process and reabsorb bicarb? No, we want to stop that process, so we give carbonic anhydrase inhibitors, so such as acetazolamide, right? Acetazolamide acetifies the blood, right? It's acidic. It's not acidic itself, but it will make you acidic, right? So if someone has too much alkalosis, we can give acetazolamide to fix it, right? Usually it's someone that has been on diuretics already, right? Like furosemide, Lasix, Bumex, bumetanide, right? Or they're on, what else? They're on like hydrochlorothiazide or something, right? So they're on too much diuretics, and when you're on too much diuretics, all those medications I just mentioned are what kind of effect on the potassium? Do they waste it or do they spare it? They waste it, right? You waste potassium, then what happens? Your K is gone, so your body's gonna say, whoa, K is gone, I'm going to go ahead and get K out of my cells and restore the K in the bloodstream, right? And it has to do that, it's exchanged evenly. So K goes out and hydrogen ion goes in, right? So K goes out to make the hypokalemia not so hypokalemic, because we know our heart wants a good K balance, and then exchange for hydrogen ions, we get alkalotic, right? The other thing is our aldosterone systems could get fired off as well, because when you're hyperkalemic, your aldosterone gets released and it starts getting rid of potassium. You're hypokalemic, it doesn't work as much, right? Also, you lose a lot of fluids, and you have all this alkalosis happening, and your CO2 on your chemistry or your bicarb on your ABG is going to start going up and up and up, and we have to figure out, do they still need the diuretic for one, and B, can we maybe give acetazolamide as an option, right? It will diurese, and it will also get you fix your acid-base balance. Okay, so that's the normal process and how we can adjust the normal process. If I'm too acidotic, right, too acidotic here, I'm going to take a little amino acid here, I'm going to break it down to ammonia, and that ammonia has a little negative charge on it, and it's going to bind the hydrogen ions, and I'm going to get rid of it in the urine. Okay. If I just have too much bicarb, my body will just get rid of sodium bicarb purely. It does have its mechanism where it'll just get rid of it and not reabsorb the bicarb like we do under normal conditions. Okay. So acidotic conditions less than 7.35, they're just going to excrete it as hydrogen ions by breaking down glutamate. And then if I'm really alkalotic, greater than 7.45, I'm going to get rid of it as sodium bicarb. And then, of course, my body's going to compensate with metabolic alkalosis, and it's going to try to get the K back in the serum in exchange for hydrogen ions, right? And that contraction alkalosis happens because of potassium wasting diuretics. So yeah, we could start a potassium sparing diuretic, or we can start acetazolamide. It's usually the better alternative, because usually they might be going to kidney failure. They giving more potassium might not help the situation. Okay, so look, just a note on potassium sparing diuretics. These are it. Those are the only 4. Right? Everything else is potassium wasting. So if you know those 4, then you know that that's it. Right? And spironolactone and eplerenone, those are the same class. Right? Those are mineralocorticoid receptor antagonists. They're usually used in heart failure. And then we have triamterene, haven't given it in a long time, but also we got our other guy here, amelioride. Sometimes you'll see that get used, but those are your only potassium sparing diuretics. Okay, so that's how your kidneys are going to get rid of acid or hold on to bicarb, or how carbonic anhydrase can be used to stop the bicarb reabsorption and make us a little more acidic. Okay, so the anion gap, we'll touch on anion gap again, right? When our hydrogen ion exchanges, when we are acidotic, right? We have acidosis here. When we're acidotic, we're going to try to fix that. We're going to try to fix that acidosis by taking the potassium and exchange with hydrogen ions, right? We're going to take the hydrogen ions, because they are causing problems, put them into the cells, right? And that's going to then fix our acidosis temporarily. And they start getting hyperkalemic. And when they start getting hyperkalemic, so shoot, let's put the K back in the cell and the hydrogen out of the cell. And it starts freaking out when it starts getting really high potassium, really high hydrogen ions, and eventually you decompensate, right? And then your cells can't operate at high hydrogen ions. You can't maintain a resting potential when you are in your cardiac, action potentials. That gets destroyed. You can't conduct across your heart, and then you go into PEA, right? Or even asystole. So when you have those situations, you've got to fix the potassium immediately, or you have to stabilize the membranes immediately. And we stabilize that with what medication? Calcium chloride. So anytime someone's hyperkalemic and they got arrhythmias, your thinking is probably due to high potassium. We know the potassium is high, and they're starting getting more and more arrhythmias. They're getting bradycardic. We can give calcium to stabilize the cardiac membrane. Does it change the potassium levels? Absolutely not. If your K is 7.8 and you give calcium chloride, it's still 7.8. All you've done is temporized it for 40 minutes, right? So you have calcium chloride, and you also have calcium gluconate. They both are going to do the same thing, but one's stronger than the other. One's 3 times stronger than the other. Which one's the strongest? The one that's in the CC, in the crash cart, right, is your strongest way, so your strongest calcium medication, okay? And calcium can actually raise your blood pressure a little bit too, which is nice, okay? So yeah, so what happens normally, besides stabilizing membranes, what happens normally, your body's going to try to fix the acidosis, but K also goes to the cells. When we have hyperkalemia, we can fix it with insulin, dextrose, beta agonists, right, such as anything that stimulates the SNS can also drop our potassium, which is nice, right? So we have beta 2 agonists, right, or SNS, or our albuterol, which is a pure beta agonist, right? It mimics the SNS, right? You give it inhaled via the mask, like it's a huge dose compared to a regular Duaneb or compared to a regular albuterol treatment, right? So that's going to bind there. It's going to do all this fancy stuff here, and eventually it'll make the potassium go into the cell, right, with that sodium-potassium exchanger up top. Right? So what else does it? Glucose will do it, because when glucose is present, our body releases insulin, and that insulin is going to bind and do all this fancy stuff and make potassium go into the cell. Right? And then giving insulin obviously is also going to, that's also going to stimulate this process as well. So those are treatments for hyperkalemia. Okay? And again, when we're hyperkalemic, usually you're acidotic, so we can actually measure, acids with our anion gap. That's cluing you in that the acidosis is getting worse and worse and worse when your anion gap is getting higher and higher, more than 12, right? So life-threatening hyperkalemia is usually greater than 6.5, greater than 7 definitely. Those are times where you need to get rid of the potassium. So you have a couple different ways you can do it. If it's causing heart problems, as we mentioned, you give what? You just stabilize the membrane with calcium chloride, right? Otherwise, we can just sweep it under the rug, right? That's what my daughter does, right? It's like you just put all the mess under the bed, right? So you just kind of sweep it all the way, put it aside into the cells. We're going to shift it into the cells, and then we're going to hopefully later pee it out, right? But what if they have renal failure? Well, now you're not. That's not going to work that great, right? So we have, in that case, if they have renal failure, we have to do what's called hemodialysis. We have to actually just take it out of the blood, right? So I thought I had it here. Yeah, hemodialysis, just take it out. If kidneys aren't going to be able to compensate and get rid of it eventually, we have to just take it out with hemodialysis. But we can sweep it under the rug, just like we mentioned with insulin. That's how bodies can do normally. We give insulin, we can give glucose, we can give beta agonists like albuterol, and bicarb you may see given on the cocktail for potassium, right? They call it a cocktail because it has all these different things in it. But bicarb actually raises your potassium when you give it IV push. If you give it as like an infusion, like a bicarb drip, it will lower your potassium for sure, right? But if you give it as a bolus, what's it going to do? Well, I know normally what happens, the bicarb attaches, it's going to exchange here, and then the potassium is going to happen here, and the potassium will go into the cells. But really, bicarb is extremely hypertonic, extremely osmolar. It's going to pull the potassium out of the cells when you give it, and that's going to raise your potassium by 0.1 when you give bicarb push. So bicarb push should not be given for hyperkalemia. Right? It's been phased out about 10 years ago, but we still have providers that will order it. Okay. Right? So as long as you give the insulin, dextrose, and beta agonist first, and say, okay, I got you, I'll give the bicarb, no problem. Right? But otherwise, those are the ones you want to focus on, right? But first priority, you got an abnormal heart rate, give calcium, and then we're giving insulin, glucose, albuterol, and then we'll do bicarb just for optics. Okay.
Is calcium pushing potassium into the cell as well? Or is it just
no, calcium is optimizing the cardiac membrane, the ion channels. It's stabilizing them, right? It's kind of activating them. Okay, and then if that's the bloodstream, right? Our bloodstream, we can change the potassium that way, but also we can eliminate it in the urine. So we can do what's called caluresis. So you can urese K, or the K, and that's like furosemide, a loop diuretic, a potassium wasted diuretic. So as long as it's not CEAT, right, spironolactone, pleromone, amiloride, or tramterine, then that'll work, right? But usually furosemides are go-to, Lasix is a go-to, as long as they pee, right? As long as they pee, that will work. If that doesn't work, we're going to make them poop it out. We're going to get out of you just any way we can, right? So we're either going to take it out aggressively via the blood, or we're going to make them poop it out. And Kxalate was retired in 2016. We don't use Kxalate anymore, right? You might still see it ordered, but it's not great. It's going to causes bowel ischemia, and doesn't work as great as these other agents here. Okay, so Lokelma, you might have seen that ordered more recently. Sodium zirconium is the brand name, right? That's what you buy your girlfriend. I got you a sodium zirconium ring, right? So then you also have patiramir. These are 3 medications we can give to poop out potassium. Okay. So yeah, so detectives back in the 40s were called dicks, right? So you can think of a big detective, right? A big dick is how you fix potassium, right? So A for albuterol, B for bicarb, maybe, right? You have I for insulin, you have G for glucose, D50, you got D for diuretics, you got H for hemodialysis, right? And you got C for calcium, and calcium is our priority if we have any kind of arrhythmias. You got K for crapping it out, all right? Kicking it out of the butt. Okay, so that's how you fix high potassiums when you have acidosis.